Hello there, my name is Carrie Woods. I'm from Gloucestershire Carers Hub. It is the 20th of June 2023. This is an information session in regards to preparing yourself as a carer for your cared for's hospital discharge. And today we are with Claire from the discharge team from the Acute Hospital Trust, who's going to go through an information presentation with you in regards to how you can better prepare yourself. Claire, did you want to introduce yourself?
Yeah, so I work as part of the sort of the therapy team. So I'm a therapy support worker. So I work with the physios and the OT. So obviously we have a big impact in people's discharge. We're not the sole we don't solely make the decision. It's done by an MDT, but we'll get into all that later on in the session. So thank you for your time today. Okay, so so welcome, and so today we're looking at how you can support on discharge from hospital. Next slide. So the aims of today would be to provide information on how you can support your relatives from discharge from hospital, maybe a better understanding on how you can support relatives when they get home, looking at sort of the understanding of terminology, wording in the hospital can be a bit daunting and things, and then maybe some ideas and tips to support once the patient is actually home. And I've got some useful contact information. Next slide, please. So, day of admission. Admission to hospital can be scary, anxious time for both patient, carers, relatives. The best thing to do is to try and stay calm and positive for yourself and focus on the person coming home. Keep that into your head. That they will be coming home, and looking at ways that you can help support this. So discharge planning will start from the point of admission. This might include staff finding out about how the patient usually manages at home and any support in place, etc. When you're seen in the emergency department, so a preliminary discharge plan might be discussed. However, bear in mind that this can change as the patient's condition changes, and with ongoing assessments and interventions. We always work with a home first approach. The aim of this is to support patients to return to their usual place of residence with the support if required. To help patients recover in their own surroundings and regain their own ability to live independently as possible. It would be our first aim. Next slide, please. So how you can support the patient while in hospital. So bring in patients' own clothes and toiletries. This will help continue with daily routines and having familiarity around them. Maybe just having one main contact family member, so there's not lots of mixed messages, and obviously staff, as much as they would like to speak to everyone, it's time. So if there's just one person that they can sort of speak to, and then it's up to them for the rest of the family to go to the main contact. Using your time with them on the ward during visiting, whilst encouraging them to sit out in the chair, practice with mobility, maybe help with exercises that as a therapy team might have given them. I've got a couple of patients at the moment, husbands are coming in and doing the bed exercises or chair exercises with them. It gives you something to sort of pass the time. Support at meal times, getting involved in their care, just talking to the nursing staff to make sure they're happy with all this. But it's the wards I work on, we've got some good HCAs, so building up a rapport with them. You're both working towards your the patient getting home, your relative getting home. So work together, and and they might have some suggestions on the ward that can help. If patient uses mobility equipment that they prefer and is not available in the hospital, or they're familiarized with it, or maybe a electric wheelchair, if I know it's not always possible, but if those items can be brought in, it helps with getting them back to what they're familiarized with, and just label any personal items and things. Bringing in hearing aids, dentures, glasses, all helps, with their daily activities of eating and hearing people and engaging. If the patient is particularly fond of food and drink items, you're welcome to bring it in on the wards. Just let the staff know, and it will get labelled and things. And any sort of activities to stimulate the mind, books, crosswords, electronic iPads, tablets, to keep in contact with family members through video calls and things like that, audio books, photos that can help stimulate the and their engagement, especially those patients that maybe have got a bit of delirium and things like that. So they're all good ideas for you to have and keep in mind. Next slide, please. So terminology. There's probably a lot of words used. I don't all know the terminology the doctors use, and so it must be even more frightening for you guys out there. So home first, you might be hearing that quite a bit at the moment. So our home first and reablement service supports returning people to home after their stay in hospital. This helps them continue their recovery in their own environment, which 9 times out of 10 you get them back into their own environment and they'll thrive in there. Regaining the ability to live, this will help getting them back to being independent and that. Staying in hospital for longer than necessary has a negative impact on how well patients recover. Ensuring that patients are given the chance to continue their lives at home. Home is vital for the long-term health and well-being, and there's some information there for you. So as a pathways, and when I use the term pathways, means leaving the hospital. So there's other so if we can't get that patient home because their needs can't be met at home at that point, there's other places that we can look at. Bed-based reablement, it might be something you've heard of. We tend to look at this as, if somebody is not able to do the stairs at the moment and bed can't be brought downstairs and it's just not possible, this discharge is usually the patient is just needing help from one nurse, one carer. Then we've got other options of community hospital, and these hospitals are county-wide. These are a step down from the acute hospital setting, and they can provide subacute medical support. So maybe IV antibiotics, people needing oxygen a bit longer, and ongoing therapy needs. Also, these hospitals can be used to get patients closer to home at end-of-life care as well. So next we've got, you might hear the term D2A. And this is a discharge to assess. So it's usually in a care home where the patient will go for ongoing assessments, see what their long-term care needs may require. This isn't a permanent placement, it's over several weeks, often finding that patients that have got overnight needs will need to go to these assessment places that they can't manage in between calls, and you know, it's the last resort. And again, like I said in an earlier slide, these pathways can change, because as therapy, we will work with the patients on the wards, you know, to get them home. That would be our aim. You might hear the term MSFD. So the doctors use this terminology if the patient is medically fit to leave the acute hospital. This doesn't always mean they are leaving immediately. It's just that they're at the point that they can leave the acute hospital, but we wouldn't send them out unless care packages were starting, equipment was in place, all prior to discharge. So all that would have to be in place before they would leave the hospital. Other terms you might be associated with care packages is OD. So that'd be one call a day, and that call could be morning, lunch, or evening, depending on the patient's care needs. BD, that would be 2 calls. Again, it could be various times of the day, depending on the care needs. TDS, that'll be 3 times a day, and then QDS is for 4 calls a day. Also, you might hear the term baseline. As therapy, we don't tend to like that word, but it's a used meaning getting patients back to their pre-admission level and what function and physical ability was like prior to admission. But please ask, you know, members of staff, doctors, whoever you're speaking to, if they're using something that you do not know or understand, just ask, and you know, we'll happily explain. So next slide, please. So what support is needed? So the ward will make a note of patients' care and support whilst they're an inpatient. If these needs cannot be met by the patient's current support, the ward may refer to therapy. So if they've come in with a change and their functional ability has changed or physical ability has changed, they will be referred to therapy to see if we can work with them to get them, you know, back to as near as possible that we can. Therapy may provide education and equipment and management techniques to promote the patient's independence. Following assessments, if the patient continues to require support, a referral will be put in to Transfer of Care Bureau. You might hear the term called TOCB. This is a team that meets daily at half past 11 and consists of a panel of different disciplines, both in the hospital and in the community, who discuss each and individual case and advice that is most appropriate pathway discharge. So we can do the assessments, we can put these referrals in. It is then out of our hands. It goes to a panel. They're the ones that are sort of making the discussion, making the decisions. We will put everything on the referrals as possible to help with those decisions. But at the end of the day, they're the ones that will make the appropriate discharge pathways. Next slide, please. So ways you can help support on discharge home. So could the person's home environment be changed? I've talked earlier, I think, about, you know, maybe downstairs living, if that is possible and there's enough space. You know, look at sort of decluttering areas to reduce falls, making it easier for them to get, to get them about. You know, make sure the environment's clean for them to come home in and things like that. You may get asked, especially by the therapy team, to provide measurements of heights of beds and chairs, and any deep steps that may be problematic for the patient. It just makes it easier to see what we're assessing. You know, if there's a certain height, you know, often not families will say, oh, their chair's much higher at home. That's great, that's fine. We need details of heights of beds, and that's usually from the floor to the top of the cushion or the mattress. So then, you know, we know what we're working with, and if any additional equipment might need to be put in place for that. Sometimes photos of living areas of tricky stairs or steps can help with assessments. You know, look at any trip hazards in the home, you know, declutter areas of rugs, you know, minimize areas in the kitchen to make a hot drink and heat up meals, so they're not going from one end of the kitchen to the next to fill up the kettle and things like that. Try and have it all in one sort of area. I know all these things I'm suggesting, it can be a bit of an upheaval on that, but all helps with their discharge. And sometimes it might not be for long term, it just might help them when they get back home initially. So maybe thinking about key safe, if we're looking at putting care in, or the home first service, they need to access the property. So you might get asked about putting a key safe in, and these can be bought from DIY shops like B&Q and that. And just also check with your home insurance as well to make sure that they're up to date with that information as well. But it just helps, so the patient doesn't have to get out, or your relative has to get out of bed to go and answer the door, because obviously, you know, that they're there to go and help and support, so that will reduce them getting up and moving about before the carers even start in the mornings. And also it helps you know, you guys, if they've fallen and that, you've got access to the property. So and pendant alarms, or wrist alarms, sensor mats and door alarms can be through adult help desk via the telecare service. So, you know, I often get told, oh, you know, they're falling and things like that. There's these sort of gadgets out there it's never going to stop the falls, but it might just raise the alarm that, you know, they have fallen or they've got out the door and things like that. So it just helps reduce that risk, and put in a bit more sort of safety. Getting rails fitted for any stairs or steps, just to help. Be prepared if any equipment we're ordering to the house, someone is expected to be there for delivery from a company called GIS. We'll be aware of we will pass on your contact details, and they will contact you directly to arrange delivery. You may get asked to take small pieces of equipment home from the wards, from us or HCAs. Just when you're visiting, make sure the boot's clear. You might have to pop something in the car ready to come home for discharge, and prepare sort of a bit of food and shopping and things for them. Next slide, please. So I just wanted to do a bit of an example. These are just bullet points for me, but I just want to talk about change of, I talked about change of pathways. So I recently had a patient was admitted with a fracture to the right arm and an injury to the right leg. So she was unable to weight bear through the right arm. Initially, when we first saw this patient, we were looking at maybe getting her to the bed-based reablement discharge pathway, But over time, and with some rehab and some practice with mobility and washing and dressing and stairs over the course of a couple of weeks, we were then able to change that pathway, and the patient actually went home with once a day home first. We did end up with downstairs living, but I put in a community referral to help them practice the stairs on discharge. So so pathways can change, and you know, our aim will be to get them home first. So next slide, please. So one of the sort of last bit of information I want to give you, some useful contact numbers. So the adult help desk, they're a great source to go to. So there's a phone number there and an email, so they will help, so they can get in contact with community teams for therapy. If you're really struggling at home with care needs and things like that, they can come out and with assessments. They're just a really useful point of contact. And I think I spoke about telecare, and you yourselves can contact directly. It's not a professional person that has to refer or anything. It's like a helpline. You know, if you've got any problems at all, they're a good go-to source. Wiltshire Farm Foods, so they're really good sort of ready meals. They're all sort of prepared locally. I've had dealings with the company, like they've come out and talked to the team, and we've tried the food. It was very tasty, and they usually have regular drivers, so it'd be the same person sort of coming out to them. So that's another good source of somebody checking in, you know, and if they know that there's any problems or something's not quite right, then that you know, they will alert. But yeah, they're a good source. And I actually use the meals on the walls for assessments. So if somebody already uses them, we can do a kitchen assessment where we see them heat that meal up, so we know that, you know, they can do that when they get home. We Care Repair is like a home improvements. Again, you know, you can contact them yourselves. They're good for any sort of, you know, basic work, rails, that sort of thing. And Lifelink. So again, for your pendant alarms and your wrist alarms, you can go through them. Gloucestershire Fire and Rescue Service. So if somebody is having to like upstairs, what we call upstairs living, so we if that's something that we're putting in place in hospital, then we will refer to the team, and they will do an assessment before discharge, because obviously need to make sure that the home is safe and fire, you know, got appropriate fire alarms and things like that. So again, you can contact them. They can come out and check your smoke alarms and things like that. And Age UK, they're another good support basis. I've spent time with them while working in the hospital, and they can support with, you know, like form filling, finance. They can signpost for shopping, cleaning, and we do referrals in hospital. But again, you can call them yourself, and they do phone checks once home. If they really are concerned, they feel it's necessary, they can come out and sort of you know, see what's going on at home. So next slide, I think, and I think that's it. Thank you.